Hello, I'm Larry Wurn. I'm Research Chair at Clear Passage Physical Therapy. This is a film for physicians and I guess some patients for physical therapy for intra-abdominal adhesions, abdominal and pelvic adhesions. We're going to be going over here the history of this therapy, science behind it, and publications about non-surgically treating abdominal adhesions and bowel obstructions. We'll also be looking at indications and contraindications. Adhesions have always been a problem in medicine, and in physical therapy we've treated adhesions post-mastectomy, after burns, for adhesive capsulitis. Now we're starting to look at treating adhesions in the abdomen and pelvis. In 2004 we began publishing a series of studies showing that manual physical therapy to treat adhesions was actually improving fertility success rates in a number of women. In order to test objective measures, we began examining women with total bilateral occlusions. Before therapy, many of them came in with total occlusions. After therapy, as we can see here, those adhesions cleared and those tubes opened, and these women started having babies. Fascinated by this, the chief of staff of the hospital, a research gynecologist, got with us and he said, we need to publish on this. This is important. We published a study in 2008 that shows a 61% success rate opening totally blocked fallopian tubes. In a much larger study of 1,392 women published in 2015, the therapy, shown in blue, again opened fallopian tubes in 61% of women with total bilateral occlusion. This rate rivaled surgical success rates. Interestingly, 69% of the patients who had never had a prior tubal surgery had their tubes opened, while only about half of those, 35%, had their tubes opened by us if they had undergone a prior tubal surgery, presumably from the scar tissue that formed. While opening fallopian tubes was a good measure of success, when we looked at the functional improvement, actual pregnancy rates, compared to published studies for surgically opening blocked fallopian tubes, we found that therapy was significantly higher in many cases. Soon we began wondering if this therapy, which addressed adhesions in the reproductive tract, might move up a little higher and address larger tubal occlusion, larger tubes called the bowels, the intestines. We began testing this and began publishing a series of case studies in 2012 based on some remarkable results that we were seeing. And one of our first patients was a 49-year-old woman who had undergone 7 abdominal surgeries in 30 months. Most were laparotomies, 5 to decrease adhesions, and 4 included treatment for small bowel obstruction. One of her last surgeries noted kinks in her bowel even after the surgery, and the stomach adhered to the abdominal wall. Before treatment, she arrived here. She had distension, nausea, vomiting, the symptoms that we see here, typically seen with bowel obstruction patients. She was scheduled to undergo an 8th surgery, a Whipple procedure, to decrease adhesions, remove the distal aspect of her stomach, her duodenum, her gallbladder, her proximal jejunum, a pretty radical surgery. Unwilling to undergo that procedure without first trying a more conservative method, she came to therapy and elected that instead. When she arrived at therapy, she was extremely weak. She had not eaten solid foods in weeks, had not had a bowel movement, in fact, in 2 weeks, and had lost 1/8 of her body weight. After 5 days of therapy, that is 20 hours, 4 hours a day, she noted a significant decrease in pain. She was able to actually ingest solid foods, and she soon regained all of her weight. With the amount of adhesions this lady had, she did return for an additional 20 hours of therapy. Afterwards, that has been over 7 years now, she has had no other surgery for adhesions or small bowel obstruction, and she was able to cancel that Whipple procedure. During the course of therapy, we also taught her to treat herself, gave her a home maintenance program, so she now understands adhesions and how to clear them on her own. In a rather dramatic case, a woman came to us with near total obstruction. She had an ileostomy. She was able to ingest a little bit of liquids, but her primary nutrition was intravenous TPN. She was afraid to leave the town. She was afraid to get far from the hospital, feared that she would die. After therapy, she reported that she could eat normally. She had just had a cheeseburger before she came in to see us, and reported that she and her husband were leaving to go on vacation out of the country. A gentleman came in to us. He had his first small bowel obstruction surgery shortly after birth. He had had a childhood appendectomy, small bowel obstructions throughout the course of his life, laparotomy secondary to adhesions. When he came to therapy, he reported persistent adhesive small bowel obstructions with the usual symptoms. In this case, we were able to get radiologic reports before and after, and we'll pause for a moment here and look at these. At the top left, we can see an obstruction before therapy. Top right, after therapy, no more obstruction. Even more dramatic, we see at the bottom left here a near total stricture, squeezing his small intestines. After therapy, the radiologist reported there was no kinking, stricture, obstruction, abdominal mass. As a matter of fact, no constricting lesions at all. We contacted this gentleman 2 years after therapy. He reported he has had no further surgeries, no SBO symptoms at all, in fact, and no other medical intervention for small bowel obstruction. Life for these patients is very difficult. The surgery is dramatic. The average patient spends over 2 weeks in the hospital, according to the government statistics. If they do have a surgery and there's an inadvertent enterotomy or a leaking of some of the contents of the bowel, could be just a tiny bit into the interstitial spaces of the abdomen or pelvis, there can be a reinfection, a peritonitis starts to occur. 18%, almost 1 out of 5, are readmitted to the hospital within 30 days after their bowel obstruction surgery. According to a mammoth study of 5 decades of surgeries, abdominal and pelvic surgeries, the journal Digestive Surgery reported 55 to 100% of patients that undergo pelvic surgery have adhesions, and 90% of those undergoing open abdominal surgery develop adhesions. The doctors are great, they're dedicated, they want to help, but the body creates adhesions as the first step in the healing process. Costs to the U.S. government and to insurers are tremendous. In 2010, we can see that there were over 100,000 surgeries costing $11.5 billion. Adhesion surgeries, there were nearly 400,000 of those, costing over $25 billion. Clearly, any conservative therapy that can help decrease adhesions and help these patients that have recurring small bowel obstructions from returning to the hospital is of huge benefit to the patients, their physicians, and to public health care. Intrigued by this and realizing the importance of this, we developed validated tests for pre and post treatment to test the quality of life, to test the safety and the effectiveness of this therapy. We published this validated study, and it is available for any healthcare provider who wants to use it. We used it and published in 2015 when we presented at Digestive Disease Week. A group of 15,000 gastroenterologists and their staff published the abstract in Gastroenterology in another PubMed journal. Results of that study showed improvements in a return to normal in nearly every domain of function that test measured, including pain, GI symptoms, quality of life, intensity, and duration of pain. For those of you who prefer a colored graph, here we can see the blue bars at the bottom represent number of patients before and after who had returns to normal. We used very conservative p-values for this study of 0.025 and studied just 27 people, but the biostatistician noted that that's plenty of people to get a good sense of safety and effectiveness to move on to a phase 2 study. We are now moving on to a phase 2 study that will involve around 300 people with treatment and control patients. Every good scientist wants to measure adverse events in any new therapy. In this case, the adverse effects are transient and not severe. The most common adverse event is temporary tenderness during treatment, some aching, some hip and back pain that passes. There's no NG tube, no hospital stay. The journal Lancet did a study of nearly 30,000 patients examining life after abdominal surgery. They found that 35% of the patients who underwent one of these surgeries returned to the hospital for another adhesion-related surgery within 10 years. About a quarter of those returned within the first year for another surgery. They averaged over two surgeries each, and surgeries continued for these patients through life. Here again, we just see over and over again that adhesions cause problems in the bowel. A recent medical text looking at our work looked at the return to surgery rate after therapy, where the expected rate for surgery would be 30% after 2 years. Our actual rate of return to surgery to 19 months after therapy was 3%. So again, we're seeing some pretty good results there. This is not a simple abdominal wall massage. This is not going to your local massage therapist for massage. The therapy really attempts to address collagenous cross-links, the building blocks of adhesions. When we look at those cross-links, we know that they form naturally to help the body heal whenever we have tissue trauma, an infection, surgery, endometriosis, inflammation. Looking a little bit more closely here in the muscle, we see tiny adhesions forming between the muscle cells, cross-links forming, attaching cell to cell. We believe that the mechanism that appears to be detaching adhesions is at the microscopic level, where these tiny but very powerful collagenous cross-links, the building blocks of adhesions, attach to each other and the underlying structure. We've been doing this for so many years that we're pretty good at finding those adhered areas. We find that when we use a site-specific pressure and sustained stretch at those areas where cross-linking is occurring, slowly those adhesions begin to detach, the cross-links begin to detach, and the adhesions begin to pull apart, kind of like pulling out the run in a three-dimensional sweater. Thus, we're starting to see that decreasing adhesions works as well in the bowels as it does in the fallopian tubes. We've lately been notified by physicians that their patients with recurring SIBO, that is small intestinal bacterial overgrowth, that is not responding to medications, that is, it begins to respond, but then the SIBO comes back, they are sending us those patients to clear the adhesions, and when they do, that bacteria that has been treated now can exit the bowel, and the patients do very well. In one of the first such cases, we noticed that a woman with recurring SIBO, the bacteria appeared to actually be eating the food that she was ingesting. By the time she came to clear passage, she had been through several medical and pharmaceutical treatments for SIBO, and she was just getting worse and worse. She was down to about 86 pounds, as I recall. After we treated her, the medications appeared to start working, and she's now regained her normal weight, and it's basically saved her life. So it's very rewarding work in those cases where we're seeing recurring SIBO symptoms. Here's a little image of SIBO blocked in the intestines. And of course, adhesions in the intestines are generally found on the outside of the intestines. Sometimes there may be some internal, mostly on the external aspects, squeezing them like a garden hose, preventing the contents, whatever they are, of moving along, stopping motility, and causing pain, obstructions, or recurring SIBO. Indications for therapy are basically recurring adhesive small bowel obstruction, GI symptoms, really anything, any unexplained pain. If you have an indication that someone has had prior surgeries 2 or 3 or more years before, and they're now having problems and you do not see a medical reason for it, and they are not responding to therapy, that's probably the person that you should consider sending to us. Contraindications, we do screen everyone's chart for contraindications, and sometimes they are huge. We do not charge for screening. We are not interested in seeing patients we can't help. We are interested in heavily screening to see who we can help and helping those patients. So contraindications, including neutrophil skewing greater than 60%. We don't want to spread any infection. We look at all of those, so those are listed here. Thank you very much for your time. I hope you found this informative. If you do want to get in touch with us, please give us a call or email, and appreciate it. Thank you.